for the kind invitation. This session is about pedal access, even though most of us don't use pedal access as the primary access site. We sometimes have to turn into this access if we're unsuccessful doing antegrade. So the name or the topic that we're going to be talking today would be superficial femoral artery intervention via pedal access. So I'm going to show you a few cases. Our first case is a 75-year-old gentleman with a past medical history of diabetes, hypertension, hyperlipidemia, was referred for right lower extremity Fontaine class 2B claudication, which we define as claudication occurring at less than 200 meters. This case was a calf claudication. Prior failed attempt to revascularize the right superficial femoral artery via antegrade fashion, including a reentry device. Past medical history as above, surgical history prior tonsillectomy, family history non-contributory, social history, current tobacco smoker, cigarette smoker, no ETOH or illicit drug usage. Physical examination is unremarkable, except for non-palpable right dorsalis pedis and posterior tibialis, Dopplerable left dorsalis pedis and posterior tibialis. Medications, aspirin, ACE inhibitors, cilostazol, and statins. This patient had or undergone exercise therapy, not supervised exercise therapy as the guidelines state. It's a little hard to obtain, but the gentleman at least tried. Ankle brachial index, right 0.48, left 0.82. And this is the first shot. So you see occluded right superficial femoral artery, reconstituting via profunda collaterals into the popliteal artery and single vessel runoff via the anterior tibialis into the dorsalis pedis. So we first attempted, once again, antegrade crossing or revascularization. We failed once again. This time we turn into pedal access, obtain ultrasound-guided dorsalis pedis access, which you will learn in the cadaver sessions that when you do ultrasound, you look at the artery and you're going to have two veins side by side. So we access, we did this case sheathless. Some operators would use slender sheath, as Dr. Kwan mentioned. I particularly prefer sheathless if I can. We advanced a 0.018 wire, I think it was a V18 wire. We end up in a subintimal space and could not cross into the true lumen. We then attempted antegrade crossing as well, and now we end up with two wires in subintimal spaces. None of them join each other, so we then turn into cart technique, in which we advance a retrograde balloon and try to break the subintimal space and create a fenestration between the antegrade and the retrograde subintimal space. Alternatively, you have the choice of using a reentry device, antegrade, and try to pop the retrograde balloon and then advance your wire. So we end up fenestrating the subintimal space. We balloon down the SFA into the popliteal. We confirm that we're back into true lumen. And now we advance a antegrade wire and drug-coated balloon throughout the entire superficial femoral artery, and this is the final result. A complete revascularization of the superficial femoral artery, maintaining the single vessel runoff.
The question is there a dissection at the end
There is a small dissection.
At the level of the DP.
Correct.
So yeah, that's a big issue. You have to be very careful, because now obviously this could turn into a major issue because you have single vessel runoff.
That is correct, and the data for drug-coated stents is quite.
Well, that's not that you can't stent that area anyway because it's the DP. So I think this is a good example, because now you have to monitor this patient very, very closely, because obviously if that DP closes, it becomes a major issue.
Correct. There's a single vessel runoff that this gentleman had. So this is a second case. This is a courtesy of Dr. Asma Kalik, who is a outstanding peripheral interventionist who trained under Prakash, and she's now an attending at Lenox Hill. This is a 79-year-old female with past medical history of coronary disease, status post-hold myocardial infarction, diabetes, hypertension, hyperlipidemia, hypothyroidism, who was referred once again for left lower extremity Fontaine class 2B claudication. Past medical history as above, prior thyroidectomy, family history non-contributory, smoker, no TOH or illicit drug usage, physical examination unremarkable, except for +1 right dorsal pedis and posterior tibialis, Dopplerable left dorsal pedis and posterior tibialis. Medications, aspirin, beta blockers, ACE inhibitors, elastazole, and statin, as most of our patients are probably treated with. Right ABI 0.72, left ABI 0.45. Now these are going to be still frames, but we'll go through them. Here you have the left superficial femoral artery, some disease, moderate disease, occludes at its midsection. It reconstitutes distally with 3-vessel runoff. There was an attempt of antegrade revascularization, which failed. And immediately, retrograde access was obtained through dorsalis pedis, advanced in a 1/8 wire into the anterior tibialis. This was able to cross the lesion, snared, externalized, as you see here. And then you have antegrade balloon inflation with Dracoid technology throughout. This is the final result. Complete revascularization of the SFA, maintaining 3-vessel runoff. The third case is a little more challenging. This is the type of case that you got to be a little careful if you're going to entertain this type of revascularization, which you will see shortly, and you should have a colleague to discuss, such as a vascular surgeon. This is, once again, a case courtesy of Dr. Khalik. I'm sorry for the misspell of her last name. The last letter is not K, it's Q. This is a 79-year-old female with past medical history of coronary disease, status post-myocardial infarction, prior bypass, diabetes mellitus type 2, hypertension, hyperlipidemia, referred once again for a Fontaine class 2B claudication. Past medical history as above, prior CABG, family history non-contributory, social history, current tobacco smoker, no ETH or drugs. Physical examination unremarkable except for +1 left dorsalis pedis and posterior tibialis, adoptable right dorsalis pedis and posterior tibialis. Medications similar to our prior patients, aspirin, beta blockers, ACE inhibitors, elastazole, and statins. ABI on the right 0.64, on the left 0.78. This is the abdominal aortogram with iliac runoff. You see the right superficial femoral artery occlude. Actually, there's an occluded stent. There's only single vessel runoff into the foot, and it happens to be the perineal. And after a failed attempt of antegrade revascularization, the attempt was now to get access to a perineal artery, which theoretically is not a compressible vessel. It's in the intraosseous space. So you got to be a little careful, and you have to have a good level of experience before you even attempt this type of access. The problem is not so much the access as what do you do when you come out. Okay, so you see here, hope you see my pointer, you have your tibia and fibula, you have this triangle here. So what you do is that you aim your needle at the apex of the triangle. So essentially going sort of blind, sometimes the needle will go into the vein, you take it out, you go in, try again, and hopefully you get into the perineal artery, then you advance a 018 or 014, whatever wire you want to use, such as what you do with dorsalis pedis or posterior tibialis access, and you do your revascularization as you would do with other pedal access. Here she was able to advance her wire, cross the occlusion within the stent. She snared the wire, externalized it, and then she did a balloon inflation throughout the entire SFA with excellent results. Now, how do we get the sheath out? It's still, now it's going to bleed. Now you have a complete revascularization. You have brisk flow into that single vessel. So the technique here is taking out the sheath and putting a TR band and inflating it with at least 20-25 cc's of air. I warn you, in obese patients, it may be a little harder. If you're going to entertain this, you better have a good level of experience, because the problem with pedal perineal access is compartment syndrome, and that'll be a disaster. So if you're starting your career, I would not recommend to use pedal access as your primary access site. You need to have a little more experience, and when your level of expertise grows, then you may entertain this complex access sites.
Fantastic.
Beautiful.
Thank you.
Awesome. All right. I guess one more point to make is, like PK talked about, having trauma to the vessel distal stuff. What you can do is you can probably, if you have dual access, you can do a sheathless procedure where you just use your microcatheter and wire. Once you cross the lesion, you can work from the top. So that way you really don't have to introduce a full 4 French, 5 French slender sheath and then have tamponade later on. So that's one of the other approaches you can do it, just to minimize the trauma again to the
So
vessel.
I have a question for the fellows. I want to ask you this sincerely. What is the natural history of claudication? Do claudicants progress to critical limb ischemia? Just, I want to shout out. What percentage of claudicants, in your opinion, think progress to critical limb ischemia? So, anybody? Well, it's probably, I mean, it's less than 5%. I mean, probably much less than 5%. I don't know. John, what do you think about maybe 5? That's pretty good? Yeah. So it's very, very low. So it's very important when you guys, when you see these advanced techniques, the idea is to show you that things can be done, but you got to watch your indication to understand the natural history of the disease. Okay, please. And I think vascular surgeons understand this. IR also, I believe, understands this. Interventional cardiology, honestly, does not understand this enough. So it's very, 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 very important that you understand this, because it helps facilitate a good relationship with your colleagues, because it is a field in which we're all working together. So you want to create mutual respect and mutual understanding of the disease process when you do it. So it's not a radial, and you don't treat it as a radial. It is not. Okay, but yes, your techniques are good, and there's a lot of cross-pollination with vascular surgery, IR, and cardiology, because a lot of our wires, they use and they've learned, and they get a lot from us. So I think we need to facilitate that. But the key is not to take a claudicant and make them an acute limb, and then call the vascular surgeon and say, hey, listen, bail me out. It's not going to work. Okay, so you got to understand that. Okay, and that's what I really want to focus, because Dr. Gujja was very concerned about this part of our agenda, but I felt that because there's so much of it being done, we need to address it, we need to talk about it, and show you that can be done, but the question is, who should it be done on and who shouldn't? And that's where a collaborative approach works, okay? So remember those stats, it's very important. It's not a STEMI. Okay, there's no mortality associated with claudication from the leg. Mortality is associated from the heart, as you all know. Okay, great.
All right, beautiful.